Awesome. Adi, Juan, thanks for joining us at the Cofactor Co-Founders by the Couch session.
Of course.
um, we were just at the Denials Management Exchange, very exclusive sort of workshop sesh, and then a couple of us stayed on for the Revenue Integrity Symposium. So just to start with, how did it go at the Denials Management Exchange? What were some of the really cool experiences surrounding that? And give me a little insight into the format that you guys did at your workshop.
I think I'll just start with the format because I think it was particularly very unique compared to any other conference we've been to. And we've been to quite a few this year that are both just like traditional conferences, some that are like quote unquote summits that are smaller groups. This one in particular, the format was they invited a bunch of denials exchange leaders to come out to Denver, and they ran very small group sessions. So 5 to 6 people at each session sitting around at a round table. And it was just a bunch of healthcare leaders that were talking amongst themselves about the difficulties they're dealing with, the patterns they're seeing, the solutions they've sort of implemented. And in particular, it was very different from, let's say, a previous summit we went to where it was also a small group, but we were actually pitching our product to that group. And here, there was no pitching. It was sort of a phenomenal opportunity for us to do discovery and actually learn about their problems. And so we spent majority of the time asking and listening to them answer questions about what patterns they see, how many denials they get, how they handle specific denials. A big topic that the sort of denials management exchange focus on was DRG downgrades in particular. And obviously, that's where the solution we came to market focused on. And it was very surprising how many of those leaders actually didn't fully understand the denials that they were dealing with. So one example of a question we got was, how are these denials actually appearing in your ERAs or in your 835s? And we had to sort of explain, actually, they're not. And they were just fascinated by the fact that they don't understand how these denials are coming in. And that was really cool.
I just want to ask really quick, was that system aware that they were receiving DRG downgrades at
Yeah,
all?
yeah,
Or,
yeah. They
okay.
just did not. This particular leader asked us, so how do I know if I'm getting a DRG downgrade through remittance advices and not just waiting for the letter? And we had to sort of explain, you don't know.
Yeah, I would say that I agree with Adi. The format was very unique, and I really appreciated the chance to be able to talk to all these leaders who come from different backgrounds, but all are in the revenue integrity or denials management space now. So you had people who come from, very clinical backgrounds, physicians, very experienced RNs, as well as people who come from, other kinds of backgrounds like more administrative. But the thing that sort of really unifies them is that they're all dealing with not only with DRG downgrades, but with denials more generally, and dealing with an increase. This is the thing that we heard over and over again, is that there's a trend that there's an increasing amount of denials. And it was really interesting because, like Adi said, there are very differing experience levels with being in the weeds of denials. And so not only was it an opportunity for us to learn about all their individual systems, how they're working DRG downgrades, how they're implementing AI, which is another trend that we saw, but we also saw them learn from each other, and we facilitated a session, which I thought was a big success, where we actually gave the leaders who were at our session the opportunity to do kind of a root cause analysis on their own system and understand where their denials were originating from, all the different parts of the revenue cycle, and really come to an understanding of, from each other and from us, of how to improve both processes and technology in order to be able to actually handle the influx of denials that they're receiving.
Interesting. Thank you for that. And I actually wanted to unpack a little bit about, what you're saying with different positions and sort of different profiles that were coming to this exchange. So can you tell me a little bit about what you thought maybe they were trying to get out of it, and really what was like the value add for them, and even, further into your session as well?
Yeah, sure. So I saw really three different profiles that were coming in. Folks who were physician advisors or were clinicians who were tasked with being in charge of denials themselves, different folks who were in charge of utilization management, and then maybe folks who were across the two, maybe just revenue integrity auditing. There were some folks who were focused particularly on government audits, for example. And they all came with the understanding that they were going to learn from other leaders in the space. But I think the cross pollination of those three was really, really important, because a lot of times what you saw is that there's a disconnect in a lot of systems between their CDI program and their denials management program. Right. And a lot of times revenue integrity or auditing comes in a completely different, time, in a completely different timeline from other kinds of denials, or from CDI. And so we saw this in our session, connect the dots between all of the different parts of, what goes into different, both appealing denied claims and preventing them, was really interesting. And I think everyone got like a lot out of that. And then in the individual sessions, people got really in the weeds. So I think that was another thing, because you're speaking to your peers, but it was so fascinating getting to hear them talk, really getting into the weeds. Like, okay, not only are they talking, oh yes, we have Epic do this, right? But it's like, what exact smart form are you using to do this, or smart phrase are you using to do this? So the level of detail that you're able to get to among peers, I think is really unmatched.
I would agree with all of that. I'll say I actually, every single person I spoke to, I asked them, like, what did you come here for and what did you get out of it? And there was a gazillion reasons why people came, from like, I'm just trying to understand what other people are doing, to I came to this last year and thought it was really valuable. But it seems like the common pattern across what everybody took away is that they don't live on an island. And every other system, regardless of size and sophistication, seems to be dealing with these same exact problems across the board, like without fail. And the way each system is handling them seems to be very, very different. And so one example was we listened to a physician who also works in CDI talk about how they internally have started building an AI tool to help them with appeals. But he got really impatient and couldn't wait for them to finish building it. So he came up with a system to use Copilot to do it. And so he went really deep into the prompts he was using, how he adjusts those prompts, how he gets contextual information into Copilot, the copying and pasting. And so many of them were very, very skeptical, but also just so impressed that somebody took the initiative to figure out a solution, because he just couldn't wait. And so I think, one, it was just, for a lot of them, I'm sure they got a lot of inspiration, but two, it's just, I'm not on an island. I'm not the only person dealing with these problems. I'm not the only person ripping my hair out. And I want to, even if I don't walk away with a ton of solutions, I can walk away feeling better knowing I'm not doing something wrong.
Yeah, I just want to give another example that I think is really impressive here, which is another clinician actually worked on a system that sort of rubric that would allow their denial specialists to score denials as to how appealable they are. And what was interesting is that she asked the room how many other people are using a denial scoring sort of tool. And tool in this case is not an automated tool; it's just a rubric. And only 2 or 3 other people raised their hand, but it was the topic of conversation, a very hot topic of conversation in the reception right after, because you saw the idea kind of spread. And for us, that was also really important, because that's actually something that we have worked to build out in Cofactor. And so it was also validating to be able to talk to them about like why we thought it was important to build out, in an automated way, and their approaches to doing it manually.
So you're essentially witnessing innovation in real time,
Yeah.
a little bit. That's very cool. And can you guys tell me, like, I just want to dive a little bit back more into the structure of the session itself. So, you mentioned kind of walking them through a root cause analysis. Can you tell me in practicality how you did this, and then maybe like what some of the results that came out of it were, maybe what some of the most surprising findings you found to be?
Sure, I can talk through the practicality. Maybe you talk about results. So, the actual structure of the session was, we first of all just did a warm-up exercise that allowed them to get familiar with each other and get everyone sort of comfortable in conversation, discussing revenue cycle together. And honestly, the actual conference itself also did a very good job of this, so conversation flowed very easily. Then what we did is we actually have a very detailed diagram of everything that we know happens in revenue cycle. So everything from all the way from patient registration all the way to an audit, right at the very end. And we printed out large laminated sheets for them to actually go through with an expo marker and actually go through and actually highlight all the different places that they think that their revenue cycle could improve, that a denial could have been prevented. And we just went through each of those like sort of one by one and used our framework that we have developed for sepsis, which sepsis is one of the most common denials that we face, and we have a really, really good root cause framework for analyzing any kind of denial, but we, in particular, sepsis. And we use that as an example, and we're able to have them actually discuss, and come up with an action plan for how to deal with the different points of failure in the revenue cycle that we saw.
Yeah, I would say that's exactly right. Right. We started with giving them a framework of how we think about things. We gave them examples of how we analyze sepsis for one of the hospitals we work with, and then we use that as a framework for them to come up with stuff. The results were really, really interesting, in particular because when the conversation started, we asked, okay, what is the most common breakdown or the number one breakdown that you experience after, marking down this laminated sheet? And every single one of them was like, oh, it's patient registration. Like, if we could fix patient registration, that would solve maybe not all of our issues, but a large number of them. And then we spent probably 15 minutes talking about patient registration. And then we said, okay, what's beyond patient registration? And interestingly, that's when it got into documentation. That's when it got into coding errors. That's when it got into just everything else that goes wrong. But every single person said, I have all these issues, but if I could just handle patient registration and get it right on the front end, that would solve everything. And the most common issues don't seem to be issues that like the best technology, the most state-of-the-art technology could actually resolve. It's all workflow stuff, from getting the right information from the patient when they come in, giving patients a way to track the right information they need to share with the hospital. Like, all of these things, technology is not the solution here. Like, yes, technology helps. The best AI models don't do anything here. It's entirely down to a workflow issue. And I think that was the biggest takeaway for me.
Yeah, I think patient registrations, just to talk about this a little bit more, is really interesting because they all mentioned that it's not only that technology hasn't helped them, it's that they actually have all gone through multiple vendors, all different vendors on patient registration, and none of the vendors have been able to solve this problem because, like they said, it's a workforce issue and it's a workflow issue. But I think the reason that it stuck out in their mind and in our minds as well, but especially from what they were talking about, it's almost like the devil you know is better than the devil that you don't. And patient registration doesn't allow you to get the real denial, right? It doesn't allow you to get the real remittance, because typically if you register your patient wrong, you bill the wrong insurance. The insurance just comes back and says, hey, this isn't my person. Like, that's not an actual denial. And then you have to go through the whole process again and finally uncover the true denial, right? And so for them, it was like so frustrating because they have this volume of things that are in essence just completely superfluous to their actual core functions, because the majority of them, they work in CDI, they work over coding or over denials, and then they just get this fire hose of claims that don't even go to the right insurance company, like much less actually are billed correctly.
So does that mean they typically see these denials come in way after the fact, and then there's not really much work they can do concurrently?
They'll see the denial come in and they'll have to rebill it, and then they get a denial maybe like 6 months after the patient's left the hospital.
We heard of an example where a patient came in and said, I don't have insurance. And then it turned out they had 2 insurance plans. And like, what are you supposed to do when the patient is, telling you they don't have insurance?
Yeah, and then of course the insurance company comes back and says, well, you didn't file this in time. Like, we're not going to pay you. At that point, like, it just creates an additional problem, right? So yeah, I think it's definitely like patient registration is almost like the devil you don't know. Like, it doesn't allow you to actually uncover what's wrong. It's just like this nuisance at the beginning.
Kind of still at the front end, was there anything regarding prior auth that you were hearing about? That's something I've personally heard in a lot of different conferences and panels, and it seems to be being thrown around considerably. I don't know if when you had those in-depth conversations?
Yeah, so I actually talked to a lot of folks who were in charge of prior authorization, including physician advisors who were doing a lot of the peer-to-peer calls. We saw a lot of big pain points for prior auth. Number one is prior auth rules change a lot. So the prior auth and authorization rules change a lot generally. You've probably seen some content on the Cofactor page about that. The other thing beyond that is just like the rules changing is that a lot of times there's a disconnect between the person who does the auth, what's actually done, right, and then what gets billed. So a lot of times we saw a lot of folks where like they'll either start by authing like procedure that's sort of in that family, but most insurance companies only let you do 2 or 3 codes, so they'll do like the 2 to 3 codes that are related, and then the physician will end up doing one of those, right? The insurance company does not like when you do that generally. And so they kind of crack down on it, and they will try to do prior auth on the most generic code, or maybe on the code that is just most common, instead of what's actually being done. And then the physician gets in there and they're actually doing, a particular procedure, and the procedure maybe takes, they planned it to take longer, or they planned it to use an additional medical device. That's a case that we heard with certain cardiac things. They wanted to use an additional medical device, but then never prior auth, because the prior auth office is only doing the most common kinds of prior auths, right? They're sort of defaulting everything to the same thing. So like not really following like the specific details of the case. And it's not because they don't want to, it's because they have to do so many of these that going into the very specifics of every case and following up with the surgeon versus the attending, who might have slightly different things in their notes, et cetera, like that's just a big burden. And then the final thing that I heard a lot was that prior auth denials are also on the rise. And a lot of times when you get a prior auth denial, it ends up leading to, let's say you get the prior auth denial, but the patient still needs the care, or the care has already been given, right? It then leads to uncompensated care and adds additional burden to the denials team. And there's not always a connect between the prior auth denials team and the normal denials team, or sometimes they get kicked back to the CDI team to do like a clinical review. It's kind of like really a lot of different processes that people use to really handle the prior auth denials. But a lot of people said that, if they could keep up with the policies about what needs to be prior auth and when, and have that at their hands, that would solve a big burden. If they could make sure that the thing they're prior authing really matches what's, the orders say, and really double checking that. And then they could make sure that the teams are able to communicate whenever a denial happens. Like that would solve the majority of the prior auth hurdles that they have.
Do you guys feel like there's maybe more potential for AI solutions here as opposed to patient registration?
Yeah, so I think there were like a couple of other themes that I really, really saw. One was not related to AI, but a lot of these systems feel the need to like litigate things. And so they are actually getting arbitrators involved. They are actually like taking these payers to court. And that was a very common theme. And there was a whole session spent on just how they're actually going about doing that. The other thing, though, that sort of is tangential to that is they're spending a lot of time thinking about their contracts. And that, I think, is a really unique opportunity for AI in particular. Is one of the common questions we kept getting is, can you tell us about our contracts? Can you tell us how compliant they are? Can you tell us what is happening such that when we go negotiate with payers, we can pinpoint to specific clauses and say, they're not complying with this, or this needs to be a clause that we need to actually add because we feel like we're being treated unfairly. And a lot of the conversation kept going back to the contract. The payer's policy could say one thing, but if your contract says something else, you're out of luck.
We saw a lot of people who even said that they're at the point where they're willing to cancel payer contracts.
Yeah.
Because they feel like the de jure, like the legal ramifications or the legal options that they have available to them when they don't have a contract are better than when they do. Because a lot of times the contract will say that you can't go to arbitration, right? And so, but the thing is that like it's very, very manual what's happening here. So we also heard that contracting teams are disconnected sometimes from the actual teams that are working denials. And so one contract that we heard of, the denials team didn't learn about until after it had already been negotiated. Okay. But the clause that they put in there was that no particular code, none of those could have peer-to-peer. So what would happen of course, like the contracting team thought this was innocuous, right? They're like, okay, fine, like, it's a small concession. But what ended up happening is that they would just deny all of those, and then there's no recourse for the physician to be like, no, I really need to do the surgery, like, and so what would end up happening is those would all just end up being denied, and they would have to go through the normal appeals process, and you'd end up with you'd end up with a much longer period until you can actually collect that revenue, and just complete disconnect.
Wow.
The other place we're starting to see a lot of the conversation around AI and denials is choosing what to appeal. So we heard of one particular system that had a 90 plus overturn rate for their DRG downgrades, but it's because they're very selective about what they actually appeal, and it takes them a lot of time to decide what to be selective about. And so, like, there was a lot of conversation about appeal scoring and where AI comes in to actually help with that.
I would actually love to just get y'all's opinion on this, because we often hear something like that where it's very selective and really just, shoot for what almost seems like a sure case versus appealing everything. And even, very large similar systems, they might say the opposite. So I would just love to hear what y'all's opinion is on how to.
So I think the be selective about what you appeal comes down to two things. You only have so much bandwidth to actually appeal things, and so you want to be selective in that sense. Two is you want to be able to go back to your payers and say, look at how high my overturn rate is. Like, you need to stop denying things, and being selective about what you appeal does that. With AI, when you go from having to spend an hour to an hour and a half on an appeal to only 15 minutes, then it's worth appealing everything. You don't have to spend a bunch of time figuring out, is this appealable? What's my case? Do I need to write this letter? And a lot of them seem to want to be able to do that. They want to be able to appeal everything and not have to be selective. And so they want the tools that allow them to do that. The problem, I think, that we're starting to see is payers are making it increasingly difficult for these providers to appeal. And so we spoke to some folks from Michigan who told us that the BCBS in that area was starting to charge them per an appeal. And that really disincentivizes them to appeal everything. And so then if those are the constraints you need to work with, then you still want AI, but not to speed you up, but to tell you what to appeal.
Yeah, I'll add to that with 2 points. The first one is a lot of people put so much effort into denial scoring. And what's really interesting about us coming into that conversation is that we have data on denial scoring, because we have customers that have large DRG downgrade problems, and we score every single one of their denials in addition to writing the appeal letter and appealing it. And what we found, and I think most people found this surprising, is that sometimes you get surprising overturns. Sometimes a case that is no worse than an upheld case will actually get overturned. And so, given that information, a lot of times people do then want to say, like, okay, well, if I have this really, really good denial scoring program, and sure, all the ones that I'm appealing should be overturned, but are there those additional ones that could be overturned just if I went ahead and appealed them, because they're marginal cases that one reviewer might agree with and one reviewer might not agree with, and just kind of, it's a luck of the draw kind of thing, right? So I think with AI, you have the ability to do that, and that's what we see our customers doing, is they're appealing a large portion of their denials, and they get a lot of surprising overturns, which I'm always very happy to see, of course. In addition to that, the other thing I would add about the making it harder to appeal, it's not only harder at the submission part, by charging a fee, it's harder at the ingestion part, because new Aetna rule, right, says that they're just paying you based off a derived DRG, right? So they don't even give you a downgrade letter. They just pay you off a derived DRG. They just pay you a lower DRG, and it's up to you to identify the underpayment, right? And then figure out, okay, I need to actually send in an appeal, even though I didn't get a denial letter or a rationale, right? And that additional underpayment detection to generate an appeal letter based off of something that you did not even get a denial letter for, I think that's going to be the next trend, because we're starting to see inklings of some payers doing that. And the second that payers start making a substantial amount of money doing that, I think other payers will adopt it as well.
I feel like we're seeing that a lot with payers in general, where they're veiling it as almost an administrative convenience, right?
Mm-hmm.
And they're actually just downgrading things without giving any sort of notice or a need to appeal, right? And so I just wonder if that came up at all, and how you guys are thinking about that.
I got a great story from one of the systems that was there. Where basically they have a clause with their payers, right, that says payers are allowed to change the policies, but the payers can't change policies in a way that creates material harm to the facility. And so this policy was changed. They started getting all of these denials. In particular, I think it was a specific DRG downgrade. And they went back, tracked those DRG downgrades. It came out to like $6 million. They tied it back to the policy change, and they went back to the payer and said, you are actually causing material harm. You're in breach of the contract. And so the behavior they immediately saw from the payer was to stop denying or downgrading that particular DRG, and they shifted their focus to another one that did not have a policy change, such that they could bring them back to neutral on that $6 million and recover the money elsewhere. And this seems to be the common pattern, which is when the payer gets called out on a specific thing, they say, okay, fine, we agree with you. We're not being fair there. We will change our behavior. But then they start enacting the same thing somewhere else. Yeah. It's very, it's a zero-sum game for them.
Yeah. And I think the sort of fake benevolence from payers, where they say like, oh, this is administrative convenience. I think we did see a lot of that where it's like, oh, instead of getting a downgrade letter now, you just have to look at the portal to see why you didn't get paid. And it's like, okay, that's actually not any better, right? It's actually harder because it breaks my normal flow. So I'm not going to necessarily appeal that. Or, just a lot of people didn't really, just were, they had particular examples from different payers, and it wasn't I mentioned Aetna because they recently changed the rules, but it wasn't just Aetna, from different payers where they had thrown things into contracts, like what Adi said, for example, that said, oh, for our mutual benefit, we have, for example, no arbitration, no peer-to-peer or whatever, right? It's just an administrative convenience. Your physicians don't have to do peer-to-peer anymore, right? Well, no, it means that like you have no route to appeal until you get the paper appeal, right? And so like you choose to do the surgery and take the financial risk, right?
Do you see, just because we were talking about AI and sort of contract management, do you see any sort of predictive AI for those types of negotiations, right? Like your example with the different DRGs?
Yes, but I actually think it's not even just about predictive. It's sort of a reactive thing of like, look, this is what's happened over the last several years of this contract and your claims. And these are the things you should think about going forward, because these contracts take years to negotiate. They're constantly meeting with their payers. It's not like I'm going to quickly redline things and send it back to you. And so they have the ability to go get this information. They don't have the manpower to do it, right? Like, it's not like they're being asked to do a bunch of rocket science to figure out what's going wrong. It's that the amount of time and effort it takes to go figure out that non-compliance and be reactive to it takes them even longer than it does to actually negotiate the contract.
And I also think that there's like a big thing of, the systems that were there that we saw are, by definition, they wanted to go to the denials management exchange. They were the people who were so full of initiative that they went and they did the analysis. They found, every single case, for example, that was being denied contrary to policy, right? These are the people who, typically the systems, are relatively sophisticated. And in addition to that, the individual people who happen to be running the programs are, they're leaders in the field. And that's why everyone was there to learn from each other. But you got to imagine all the systems that weren't there, all the systems who don't necessarily have that example and other peers to learn from, who are having the exact same problem but don't even know it, right? And I think there's a big part of like, having technology be breaking down the barrier for things that, like Adi said, are not rocket science, but are just kind of like best practices that take so much time that are just, they're infeasible for most systems.
I will say though, I do think there are some opportunities for being predictive in that, like, if you can track across the board what payers are doing in different places, you can probably see what they'll do in other places over time, right? So if you see BCBS acting a certain way with certain hospitals in Illinois, you might be able to figure out what they're going to do in Georgia down the road. The other thing is, if you're sort of tracking the payer's behavior and their patterns, over time it might get easier to predict what the next policy change is going to be or the next big shift is going to be. But I think there's a lot more value in just understanding everything that's happened such that you can negotiate, as opposed to in real time, can I adjust? Because a lot of it is just like a knee-jerk reaction.
I'm going to switch gears a little bit. Uh, One thing that has been obviously a very common trend these last few months is a wave of systems are in the midst of transition to Epic or have announced they're going to transition to Epic over the next couple of years. I'm guessing several of the systems you guys spoke with were doing the same. Was there any sort of crop of best practices, any sort of common problems they were facing? And, I think we always hear, oh, we're transitioning to Epic. That's going to be a whole undertaking. We have a million things to do. But like when you get, was anybody actually willing to get into the weeds about that?
Yeah, so I was actually at a session where that was pretty much the primary topic of discussion. We saw several systems, I would say a couple of systems where they're going from the Oracle to Epic transition right now, with go live dates in the next couple of years. And there was a lot of learning from other Epic systems about what the best practices are. One of the interesting things that we learned is that almost every single person that we talk to uses some sort of, billing indicators, what they call it, some sort of artificial tag in the actual record inside of Epic to mark things as having been, for example, DRG downgraded or having been denied in a way that sort of comes in via denial letter, not necessarily via an ERA. So it's almost adding like a fake cart code. And the reason that they do this is because Epic doesn't naturally have good analytics on how to track DRG downgrades, on how to track, recoups or, these really complex kinds of denials. And so they've come up with these sort of like jerry-rig systems where they add an additional billing indicator and then they add a report on top of that. And then they also use that billing indicator to map from when that letter comes in, let's say, they add that billing indicator and then that gets routed to work queue for the denial team to actually work, right? And so that sort of workflow where they're sort of honestly manually labeling things using kind of this like artificial cart code, this billing indicator, really drives, I would say, like 90% of the reporting about these complex denials, which I found honestly kind of crazy. The other thing that we found is that there are folks who are who Epic has different levels. You can have the Epic's foundation pack, and then there's people who invest a lot of time in building out, very, very, very deep and detailed custom versions or custom RTM workflows in Epic. And within the Epic, foundations pack, a lot of times the level of reporting that people have is relatively limited. And so we found a lot of leaders will use Epic plus spreadsheet, believe it or not. And it's not only because, it's not because Epic is obviously doesn't have the information, but because they can't pivot it in the right way. They can't do all of this. So we saw a lot of like what we do is we track everything in Epic using this billing indicator, and then they dump that to to a spreadsheet, and then that spreadsheet then gets fed into Power BI, and we make like a graph in Power BI from that. And that like 3-step workflow to get any amount of information, oftentimes they actually employ a full-time data analyst on their team just to do this this kind of work. I thought was just really, really cumbersome. But then there were systems who had built out really, really deep integrations and had very good reporting. But there is a trade-off to it, which I found very interesting, which is that those systems can't get updates from Epic as quickly because Epic Foundation, you get the updates almost right away, right? But if you have a custom integration, they have to make sure that it's compatible with all the custom things that you've done, right? And so Epic's coming out with new features right and left, right? Right after this conference, I went to the Open at Epic conference, and I got to see all these amazing new features that Epic's going to come out with. Well, the systems that have the really, really good RCM package, oftentimes those systems will actually get those updates later, which can prevent them from being able to do some more advanced features. And that's simply because of the compatibility. So, I would say that, Epic by far was the favorite EMR at the conference for sure. But there's a really big gap that people saw when they're in the foundations only. And then there's a trade-off whenever they actually go into the full RCM workflow with Epic.
This is not exactly a comment on Epic or direct answer to your question, but I was surprised at how many of the Epic systems in particular that have some of these things set up are still tracking things through Excel. One system, actually probably the most sophisticated one that had the best reporting set, gave a really in-depth explanation about how they do it. Somebody said, or what they do. Somebody said, how do you do it? And their response was, we have an Excel sheet.
Yeah, so we saw some folks who were like, "Oh yeah, we have an Excel sheet, but don't worry, we're on the queue so that in a year we can get reporting." I'm like, okay, that's a really long lead time, only to be also then have the trade off of being cut off from future updates, or at least have a longer lead time for future updates.
There's, I know there's a couple systems like Mayo Clinic created REI, the Revenue Education and Initiative Platform.
Mm-hmm.
and I think a couple of the larger systems have that capacity. Do you think that's like a realistic way to drive your RCM innovation and analytics going forward, or where do you see kind of that future lying?
Yeah, I can comment this. I was actually in a session where they described this. Um, I think that internal innovation from the systems is always powerful because no one knows the problem better than them, for sure. That's always going to be the case, right? But what we find is that even with those platforms, even whenever they develop an internal platform, like let's say with the REI, or we saw other ones, those platforms can be fragile. They can be subject to how much time that individual has to actually maintain that. I think Mayo Clinic has done an outstanding job because they actually tie that platform to their performance metrics, and so as a result of that, like it provides an incentive to continue maintaining everything and making sure that everything's well. And of course, Mayo Clinic's a very well heeled system, so like they have resources. But I would always sort of encourage internal innovation, but at the same time, I think that there's no level of internal innovation that can really match the level of dedication to a particular problem space that a vendor can have, right? So a lot of times, like with a lot of the internal innovations that we saw, it's not that there was anything wrong with them. They're really good. Great that they're thinking about it in that way, but the vendor solutions that we see, including us, right? We spend every single day, every single day for our entire, work week, for our work year, etc., like thinking about this one set of problems. Whereas these leaders oftentimes have so many things on their plate that, and they oftentimes have a lot less staff dedicated to those systems. And so, yeah, I think there's a trade off between internal innovation and vendors.
I think the really good example of this is the physician that was using Copilot. They'd been working on it for 6 months. He got so impatient, said, okay, I'm just going to figure out how to do this myself. And then he got asked, okay, how long before you can do a new denial type? And he said about 3 to 4 months for each one. He doesn't have the time or the patience for that. And frankly, the system's bank account doesn't either.
That makes a lot of sense. I would love to hear a little bit about UGC, just kind of some of the quick takeaways. What were some things you were witnessing, and then kind of your experience at the Symposium as well. That was maybe more traditional sort of conference.
Yeah, so I can start with the Open Epic conference. So actually, what's interesting is that historically, Epic has only held conferences for its users, meaning its health system users. This is the first ever developer-focused conference. So folks who are actually integrating with Epic. It was called Open at Epic, and it was a really amazing learning experience and community experience to be able to see, everyone who's helping. Who's helping the health systems, with all these different problems, and are integrating with Epic. I'll give you my sort of two big takeaways. The first one is there needs to be a lot more sharing in this space of best practices. So we have been very, very lucky with our integrations journey. We're on Epic Showroom. We have been part of vendor services. We have really good network of folks who we work with to be able to be very good at integrations, and a lot of our instincts were and our practices were validated because they actually presented, here's the best practices for XYZ. But then there's places where we could have saved ourselves a lot of heartache and time if we had that. And I think Epic has never really before, and really no large inpatient EMR has really done this, had taken the opportunity to say, here are what the best practices are for working with our customers, with our systems, right? And we really got a lot of sessions that were just here's the best practices for how you go through the integrations process with a large system. Here's the best practices for doing a fire integration. Here's the best practices for using Tefka. All these things that literally are sort of specialist knowledge. Now they were shared across the community. So I think that was really, really powerful. And I would continue also to urge, there was so much information about standard space. So that means government mandated integration pathways. And really that the standards-based integration pathways are really, really lacking or really new in terms of revenue cycle. So they're very focused on, makes sense, on clinical care. Great. I think that's amazing. But for all of us who are working in revenue cycle, I think we saw that people are starting to think about revenue cycle in terms of, the different ways that you can integrate, but it's not mature yet. So there's a really big opportunity for, everyone who's currently in this revenue cycle space to really focus on, how do we make sure that in the future, like, we can always integrate with hospital systems and not have to do these, like, tricky things where you dump to an Excel sheet or whatever. Like, we never want to do that, right? And luckily we don't have to, but it's still a very nascent space. So those are my two big takeaways. And then apart from that, I'll also say it was my first time at the Epic campus, which was amazing. It was you always hear that it's sort of larger than life, and it really is. So yeah, I enjoyed that as well.
So I guess context is that, Tuesday, Wednesday was the Denials Management Exchange. It was very focused on CDI leaders, actual denial specialists. We talked a lot about DRG downgrades. We talked a lot about readmission denials, which, by the way, I didn't mention this. It's the second most common sort of denial that seems to be on everyone's mind is readmission, and then sort of level of care. And then Thursday, Friday was the Revenue Integrity Symposium, which very similar theme, like overarching theme, but a very different set of people, which were folks less CDI focused people and more revenue integrity. So we were talking to people that were thinking about underpayments as opposed to CDI. And the very common theme that we seem to I seem to grasp or walk away with was all of these hospitals are being forced to do obviously charge master reviews every single year. And they don't have solutions for this, actually. All of the technological solutions, for the most part, the most common thing I heard was, I just keep getting false positives, and so I'm just going to go through it myself. And that seemed to be the most common pain point across the board. The second thing was, obviously, you're constantly being audited by payers. And to prevent that, the more sophisticated systems are doing internal audits on a very regular basis. The lack of sophistication in their audit process and lack of standardization was, I don't want to say it was surprising, because they don't have as much bandwidth as you would hope, right? They're running hospitals, but they're not doing it to the extent that they should be. And that in itself is creating more audit problems for them down the road, because they're not being, they're providing excellent clinical care. They're not doing it in a quote unquote compliant way. And I think there's just, my big takeaway was there's just so much opportunity to help them actually get that right.
Actually, I think part of it too is there's a difference between the reason something happens and the root cause, right? And what I noticed a little bit myself was they start with the reason and audit through that lens rather than auditing through the root cause. Yeah. Well, Juan, Adi, thank you so much for kind of our first ever Cofactor co-founders at the couch sesh. We don't have to call it that. I just want to thank you guys for giving us some time and some insight. We had a blast at these conferences, and hope to keep giving it to the people.
Absolutely. Thank you.
Cool. Thanks.